Hey everyone, welcome to the Cardiac Care Unit. I'm your attending today, and we've got a seriously packed high-yield explainer ahead of us. We're going to walk the wards and tackle 3 completely life-threatening clinical vignettes. So if you're gearing up for your USMLE Step 2 or Step 3, or just looking to sharpen your clinical decision-making, you're going to want to pay close attention to this. We are stripping away all the fluff. We're focusing strictly on exact management steps, and more importantly, those deadly traps that board examiners just love to set for us.
Here is the roadmap for our rounds today. First, the hyperkalemic heart. Second, acute uncomplicated pericarditis. Third, taming torsades de pointes. And we'll wrap it all up with our bottom line board review.
All right, let's step right into room 1, the hyperkalemic heart. So, we've got a patient presenting with some pretty concerning vitals and a known history of spironolactone abuse. Here is your classic clinical vignette. The aldosterone antagonist impairs potassium and hydrogen ion excretion at the distal nephron, right? And that leads to a non-anion gap metabolic acidosis and, of course, drug-induced hyperkalemia. You check the monitor and you see peaked T waves and a whitening QRS. These are classic red alert signs of cardiotoxicity and impending ventricular arrhythmia. So what is your very first step?
Broom, if you said IV calcium gluconate or calcium chloride, you are absolutely correct. When you see ECG changes like a wide QRS from hyperkalemia, you literally do not have time to wait around. The myocardium is incredibly unstable right now. Your absolute priority, your #1 goal, is urgent stabilization of the cardiac membrane. And IV calcium is the exact tool for that job. Basically, it buys you the critical time you need to actually fix the underlying potassium issue.
Let's break down the strict algorithm here. Step 1 is always membrane stabilization with IV calcium if those ECG changes are present. Only after the myocardium is secured do you move to Step 2, which is shifting that potassium intracellularly using insulin and glucose or beta agonists. And then finally, Step 3 is elimination via diuretics, binders, or dialysis. Here's a massive board alert for you. Absolutely no potassium-lowering therapy should ever precede membrane stabilization when there's myocardial excitability. Period.
Okay, let's dive into this and look at the classic distractor answers the examiners are going to throw at you. You might be really tempted to discontinue the spironolactone immediately. And long-term, yeah, for sure. But acutely, it does absolutely nothing to address the immediate, life-threatening risk of an arrhythmia. You might also see sodium bicarbonate pop up as an option for the acidosis. But remember, bicarb only helps shift potassium after you've already secured the membrane with calcium.
Moving right along, let's head into room 2, acute uncomplicated pericarditis. Okay, our next patient is sitting up, they're leaning forward, and they're complaining of sharp pleuritic positional chest pain. You take a listen, and you hear a very distinct pericardial friction rub, plus they had a recent viral prodrome. But crucially, they are hemodynamically stable. There's no fever, no immunosuppression, no signs of cardiac tamponade. The ECG shows those pathognomonic findings we always look for: diffuse ST elevation and PR depression, along with reciprocal PR elevation in lead AVR. So for this acute, uncomplicated, and likely viral pericarditis, what is your first-line therapy?
The gold standard guideline-directed move here is a high-dose NSAID, like ibuprofen or aspirin, combined with colchicine for 3 months. This combo is just highly effective at reducing the pain, and it markedly lowers the rates of recurrence. Now, keep in mind, because you're prescribing high-dose NSAIDs, gastroprotection with a PPI is heavily recommended. You're also going to advise activity restriction. That means absolutely no strenuous exercise until their symptoms and inflammatory markers, like their CRP, have totally resolved. Honestly, hospitalization isn't even mandatory for a low-risk profile like this.
Let's rule out those heavily tested, incorrect therapies. Why wouldn't we do a pericardiocentesis? Well, invasive drainage is strictly reserved for cardiac tamponade or if we suspect purulent pericarditis. What about IV heparin? Never. It increases the risk of hemopericardium, and this diffuse concave ST elevation is not a territorial STEMI that needs anticoagulation. Now, high-dose prednisone does offer rapid pain relief, but we avoid glucocorticoids initially because they actually increase the risk of recurrence and prolong the disease course. You only reserve steroids for when NSAIDs and colchicine completely fail or are contraindicated. And finally, broad-spectrum IV antibiotics, totally useless and potentially harmful for a viral or idiopathic presentation.
Next up, room 3, taming torsades de pointes.
All right, take a deep breath, because things are getting real. This is our highest stakes scenario yet. The telemetry monitor is going crazy for a patient who is currently taking the tricyclic antidepressant amitriptyline.
Torsades de pointes literally translates to twisting of the points. It's a deadly polymorphic ventricular tachycardia triggered by prolonged repolarization, which shows up as a prolonged QT interval on the ECG. So how do we get here? Well, at high doses, amitriptyline blocks fast sodium channels and delays potassium efflux. That delayed potassium efflux prolongs the repolarization phase, it widens the QT interval, and perfectly sets the stage for torsades.
You glance at the telemetry and you witness a documented, self-terminating burst of this polymorphic VT. The patient is currently hemodynamically stable, but guys, we are sitting on a powder keg that could degenerate into sustained ventricular fibrillation at any second. So, for a stable patient with a non-sustained burst of torsades, what is the immediate evidence-based therapy? You've got to go with IV magnesium sulfate, specifically a 2-gram dose pushed intravenously over 10 to 15 minutes. Magnesium is the absolute drug of choice here. It works super rapidly to stabilize the myocardium by modulating those L-type calcium channels, which suppresses the early after depolarizations that trigger the arrhythmia. And here is a massive clinical pearl for you. You give IV magnesium whether their serum magnesium levels are low or completely normal. It's safe and it drastically reduces recurrence. Once you've pushed the mag, you can parallel process, stop the amitriptyline and correct any other electrolyte deficits, like pushing potassium to high normal.
Listen, this is absolutely crucial. You must know exactly which antiarrhythmic saves lives, and which one, well, ends them. You must give IV magnesium, but you never give amiodarone for torsades. Amiodarone is fantastic for monomorphic VT or refractory VF, sure, but it inherently prolongs the QT interval. Giving a QT prolonging drug to a patient who is already in polymorphic VT because of a prolonged QT, that's going to aggravate the arrhythmia, worsen their instability, and potentially be fatal.
Let's clean up the rest of these wrong answers. Sticking an outpatient Holter monitor on this patient without treating them? Incredibly unsafe. They need acute suppression of those early after depolarizations right this second. What about synchronized cardioversion? Remember, our patient is stable and the burst self-terminated. You don't shock a stable patient. Plus, if they do become hemodynamically unstable, torsades requires immediate unsynchronized defibrillation because the rhythm is polymorphic and lacks a consistent R wave for the machine to even sync on. Lastly, what about a beta blocker like metoprolol? Look, it's great for congenital long QT syndrome, but it does absolutely nothing to acutely treat drug-induced torsades, and it might even cause bradycardia, which just worsens the torsades risk even further.
All right, wrapping things up, let's head to room 4, bottom line board review.
You guys get amazing on the wards today. Let's head back to the workstation and lock in the highest yield takeaways from this explainer so you are ready for test day. Number 1, for hyperkalemia with ECG changes like a wide QRS or peaked T waves, your immediate first step is always membrane stabilization with IV calcium. Lower the potassium only after you protect the heart. Number 2, for acute, uncomplicated, stable viral pericarditis, your first-line therapy is high-dose NSAIDs plus colchicine for 3 months. Do not drain the fluid unless there's tamponade, and strictly avoid steroids because they increase recurrence. Number 3, for a stable patient with drug-induced torsades de pointes, push IV magnesium sulfate. Avoid amiodarone at all costs, as it will only prolong that QT further.
Excellent work today, everyone. You now know exactly how to stabilize the myocardium when the alarms start ringing. But I'm going to leave you with this final thought. You know how to put the fire out today, but do you know how to identify the hidden triggers, the silent drug interactions, the subtle electrolyte shifts before the next arrhythmia even strikes? Keep mastering that underlying pathophysiology, keep pushing your clinical knowledge, and I'll catch you on the next round.